Welcome to Derms on Drugs, a video podcast brought to you by scholars in medicine. Derms on Drugs is where cutting-edge derm meets so-so comedy. I'm Matt Zires, and each week I'm joined by my residency buddies, Laura Ferris and Tim Patton, and we use our 60 years of combined derm experience to discuss, debate, and dissect the hottest topics in dermatology. It is everything you need to know to be on the cutting edge of dermatology, and it'll be the most fun you've ever had while learning something useful. New episodes drop every Friday, so make sure you set your calendar. And let's go ahead and get into it this week. We've got one of our patented six-pack episodes where we're going to talk about 6 of the coolest articles that we've seen recently in the literature, the same way we would talk about them if we were sitting on Patton's back porch having a 6-pack of beer. So, I don't know if Ferris drinks beer, but she's a little snooty, but Patton and I certainly would be. So, Dr. Ferris.
I do have in Sauvignon Blanc, but that's okay.
there
I
we
like
go.
a good beer too.
That sounds right.
Yes.
So,
all right. So I'll start with my first paper. So this was in JAMA Dermatology, Immune Checkpoint Inhibitors in Field Cancerization and Keratinocyte Cancer Prevention, Cox et al. So this was a clinical trial that was really not an intervention to treat AKs with immune checkpoint inhibitors, because that would be a little bit over the top. But what they did was they took 23 adults who were immunocompetent, who were starting a PD-1 or PD-L1 inhibitor for another cancer, and who happened to also have AKs. So these are people who were going to have it for at least 6 months. They had to have AKs on their forearms. They couldn't have had like recent topical 5-FU or anything like that. And what they did was they basically did a count of forearm AKs at baseline, and then at months 3, 6, and then 12. And so these people were pretty, AKE. They started with about 47 mean number at baseline, and then it went down to 14 at 12 months. That was statistically significant. So, AKs, that's nice that they decreased the numbers of AKs. How about keratinocyte carcinomas? So what they did was they looked in the 12 months before they started their checkpoint inhibitor and the 12 months after they started it. And their, total numbers basically decreased from 42 across the 23 people in the 12 months before to 17 in the 12 months after. So the number of SCCs decreased from 16 to 5. These really didn't reach statistical significance, but realize this was 23 patients. So kind of interesting. Are we going to start doing this for AKs? Like, I thought this Klisyri was an expensive AK treatment. Like, I can imagine that a PD-1 inhibitor is probably going to be a really expensive AK treatment. Probably not, but maybe at some point, like in those terribly sun damaged, everything's an SCC or an AK, maybe you only need maybe you don't need 6 months, maybe you need a dose or two. These will eventually go biosimilar. This cost will come down. Maybe that would make sense. So I thought it was interesting. If you look at the picture, there's a nice photo in the, as a figure. You could see markedly improved AKs.
Did it affect their BCC numbers to the same extent as the SCC? Because I think of BCCs as pretty non-immunogenic. I don't know if that's true, but that's how I think of them.
Yeah, it's interesting. If BCCs, they have a high tumor mutational burden. I think the biggest reduction was actually in squamous cell carcinomas, but I have to go back and look at the actual numbers.
And did it say anything about if there was any correlation between adverse events? So, I think of with imiquimod, right, or calcipotriene 5-FU, other things that I think of as immunotherapy for AKs. I think of it as being the worse their symptoms are, the better it works. Or did they not really even talk about, did their AKs get inflamed, or did they just go away?
They just went away. There wasn't a lot of inflammation. So it sort of looks like it's mechanistically different than what we see, remember in residency, because you don't see a lot of people getting, systemic 5-FU anymore. But remember, we would see patients who would get put on systemic 5-FU for head neck cancer, and then they'd come in and their AKs were all lit up. It seems like it's a little different from that. So
it looked
Yeah.
like in the photo, and maybe I was making this up. Didn't it look like he was developing vitiligo as time went on? Did they do any sort of association of you got a better response? It was probably too small of a study, but did you get a better response if you had like a cutaneous side effect, like you do with maybe, like melanoma, things like that?
I don't think that it was powered enough to see that. All that I really, and I have to go back and look at the paper again, but what I kind of noted was like the adverse event profile looked like every adverse event profile in, PD-1 inhibitor
Which would
studies.
be a big drawback to treating AKs. Now you have diabetes and adrenal insufficiency and hypothyroidism.
And you may have died from colitis, but otherwise it's all good.
Right.
Your skin's not smoother.
Yeah. Yeah. Most common adverse events were rash. So 30% of patients had maculopapular rash. One person actually got bullous pemphigoid in the study. Yeah. And they didn't really correlate it. There was no difference in the clearance of AKs and those with cutaneous versus non-cutaneous adverse events. That's right. The outcome that they used was, they sort of said like good response was greater 65% or more of AKs cleared. Not good response was less than 65%. And the people who had cutaneous adverse events weren't more likely to clear their AKs.
Okay. All right, I'm about to give you guys a quadrillion-dollar idea here. You ready?
Okay.
Yeah.
Topical PD-1 inhibitor. Could have a tube of that stuff for $24,000.
Yep.
And it would get rid of your AKs.
Yeah.
So I think it would have to be not an antibody. That's not going to do well topically, which is what these are.
Oh,
but
I didn't realize they were
small
antibodies.
molecules, like you can have small inhibitory RNAs that could do it. So maybe.
We need our cosmetic chemist back.
Okay. All right, Pat.
$100 idea.
Let's move on to article number 2, Pat.
All right, so I did intradermal Botox for melasma. It was intradermal botulinum toxin A for melasma, a randomized split-phase study trial, an in vitro study, and its anti-melanogenic effect. It was by Thanasarnexorn et al. In the January 2012 edition of Derm Therapy. It had 2 main parts: in vitro data of abobotulinum toxin, so this is Dysport, effects on melanoma cell line, and the clinical trial data. Details of the in vitro stuff. Basically, it seemed to decrease UVA-induced melanin content and tyrosinase activity, and yet it was not cytotoxic. For the clinical effects, 12 women...
Did they have any explanation for how that, like, I think of botulinum toxin as I don't remember what the hell it does. It cleaves something.
It prevents acetylcholine release from the neuron. So acetylcholine doesn't go and bind to the neuromuscular junction. Right. I'm the same way. I was looking, these cells do have, if AI is correct, they do have the capability of releasing acetylcholine. And then I'm like, but is that, so does the acetylcholine then bind to the cell and make melanin? I don't think they know the mechanism here.
Okay.
I think they're like, well, maybe Botox has tyrosinase activity like every other thing that can potentially lighten the skin, or not tyrosinase, but inhibiting tyrosinase. That I thought the same thing. I'm like, why would this work? If you put Botox in with a melanoma cell line, why would you expect any effect on these? And they kind of were like, maybe it does this. They didn't really get into it.
Okay. Is it like the release of like little granules or something? I don't know. Like
no, I don't know.
Transport the cell. All right.
Yes, that's why I didn't want to go into details of that, because I didn't know the details. So let's move on. For the clinical effects, 12 women were enrolled and they received Dysport on one side of the face and normal saline on the other. Concentration of Dysport was 66.67 units per mil. That seems like the similar dilution for if they're doing it for fine lines and wrinkles. It was injected intradermally. You would achieve a 2 millimeter wheal, and injections were spaced 2 millimeter apart. So at 3 months, they had different measures of melasma. The MASI, the PGA, and patient satisfaction scores were all statistically significantly better for the side of the face treated with Dysport compared to controls. So now, right? We talked about skin lightening agents for melasma. We have hydroquinone, arbutin, cysteamine, licorice, tretinoin, vitamin C, kojic acid, thiamidol, 4N-butyrresorcinol, azelaic acid, tranexamic acid. So we have more things to treat melasma than melanoma. And no one should ever have melasma ever again. That was my
None of
takeaway.
them work like shockingly well, right? Well, yeah.
I mean,
like
they all
a
scored.
setup for like facial drooping, right?
Yeah, they all scored well, but you look at the pictures and you're like, it's a little bit lighter.
I looked at the pictures and it was like the pictures where you're like, I think that's just blurry. I think it's just blurry.
But they did use, scoring, and the assessors were blinded to treatments. Was I blown away by the pictures? No. I mean, given that we have 37 other things to lighten the skin, I think Botox is way down on the list for me because, right, you will get a droopy face like Ferris when she got her rosacea treated with Botox.
That was a good residency story. I did try half of my face treated with Botox.
Yeah. You didn't have
rosacea. It did not work for the rosacea. I did have facial hemiparesis. Right. It's the longest acting Botox I've ever had in my life.
When you didn't have to count mice scratching their ears.
I did not.
But yes, you did have to do that.
And then I published myself. It was good.
Did anybody make you wear a collar of shame?
No, fortunately. I couldn't eat a sandwich for like 6 months because I couldn't actually get my lip up enough to eat.
The food would just fall out of your mouth.
Yeah.
It was really attractive there for a while.
It was very attractive. Never to be done again.
All right. We're moving on to our next one, which is, I got to say, this is an early contender for worst article of the year. And so title of this article, Unmet Needs of Effective Advanced Systemic Therapies in Moderate to Severe Atopic Dermatitis Patients in the Target Derm AD Registry. And the main takeaway for this article is I am going to be ignoring everything that comes out from the Target Derm AD Registry because this data is just crazy. It's ridiculous. So the takeaway was that Dupixent doesn't work. And so their takeaway was that if we look at how good their rash is doing, IGA times BSA, so VIGA times BSA, multiple studies have shown that that's a good determinant of efficacy. According to that, half of people did not improve on Dupixent. And when I say this is ridiculous data, it is just so different from the clinical trial data and from every single dermatologist who's ever used Dupixent's data, who's ever used Dupixent. So, and half of them, I'm sorry, I actually was looking at the wrong thing. 2/3 of people, their skin did not improve on Botox, on Dupi. In terms of quality of life, half of people lacked improvement in their quality of life whenever they went on Dupixent for their moderate to severe atopic dermatitis. When we look at itch, mood, and sleep, 85% of people did not improve, right? We look at depression, 80% of people didn't improve. We look at anxiety, 80% of people didn't improve. Like I found this so unbelievable that I actually reached out to one of the authors and was like, how do you explain this? This is crazy. And their answer to me was, well, derms are just satisfied with people not having very good results. And I was like, I was speechless. I was speechless.
So patients would come back to us and say, I'm not really much better. And we would say, yes, you are. That's just, the numbers were just not believable. Is there a problem with, what's the problem? The registry? What?
Were they not as severe at baseline, so it's harder to measure it? Because it's more of a real world setting, right? So, was that what it was? Were they not washed out from other drugs, so there wasn't as much room as when you put somebody in a clinical trial and your numbers look really good, right?
That's kind of what I was hoping for.
Yeah,
but it didn't. I can't explain it, and that's why it makes me say, Like if
Just
this
ignore
is
it.
supposed to be a real world registry, this is not real world.
Yeah.
Like it didn't. And so it makes me say, however they designed this registry, like it's any data that comes out of it, I can't believe at all. Because if it's saying that 80% of people, Dupie doesn't help their itch or sleep, that's just ridiculous.
Yeah, I wouldn't. I'm the same way. Like you just put the paper aside and say, I'm never reading another paper coming from this registry because this is clearly not accurate.
Like
or the way that they measured, that they looked at data here didn't give us like the real view into like what happens. Like we know when you have somebody who starts, like a lot of times when you put people in registries, they're your long-term patients, they're on their third drug with you. They're not really washed out, treatment naive. They're maybe not that bad when they're switching over to Dupie, right? Like that's kind of was my take on it. Like this is the issue with with registry data. So if you look at a lot of registries like they pick out only those patients who have really severe disease. And that like the kind of clinical trial inclusion level severity, and then look at how they improve.
But the reason that the people so it was essentially 100% of people who went on advanced systemic therapy were people who went on Dupie. And that's because of when they were doing this registry, when they started enrolling people, it was before there were even other drugs available. So it wasn't like these were people who had failed lots of other stuff. I can't understand. Like I don't also hate to say that. I don't know how it's so unbelievable. It's hard to believe it got published. Like it's just, I don't get it. I don't understand. So yeah, that's my takeaway though, is I'm not going to believe anything from the Target Derm AD registry.
Me neither, man. I'm with you.
Woo!
Woo!
All right, Derms on drugs, not approved. All right, let's move on to our next article. Dr. Ferris, what do you got?
So this is switching gears. Frequency of androgenic cutaneous adverse events associated with levonorgestrel IUDs, an analysis of the FDA event reporting system database. This is CASARD, which is out of Cleveland Clinic. So this was a paper where what they did, we all think, I know that progesterone IUDs make like acne and hair loss, like they have hormonal effects. They're like, no, it's just local hormones, but we don't really believe that. We know that they make acne worse, right? Yes. So what they did, I thought was kind of clever, was that they looked at spontaneous reporting of AEs for these progesterone IUDs and for the copper IUD, right? So copper has no progesterone in it. And they said, is there a difference? And so what they found was that if you look at odds ratios, if the copper is 1, if you look at like Mirena and Kyleena and Skyla, they definitely have higher odds of having acne and alopecia and hirsutism. Now, the little like kicker, like the odds were like, sort of aggregating them all, like 3 times more acne, about 6 times more alopecia, and about 15 times more hirsutism. The kicker of all this was that there was one that didn't seem to show it, which was Liletta. And that is a 52 milligram IUD, levonorgestrel IUD, which is basically like identical to Mirena. And then the other two, Kyleena and Skyla, are 19.5 and 13.5 milligrams. So they're lower and they have it, but for some reason, this one Liletta was not associated with it. So, I was like trying to look up and figure out why is this. There, you can measure the rate of release of levonorgestrel from each of these, and it's kind of the same: 21 milligrams per day with Mirena, 21 micrograms per day with Mirena, 20 micrograms per day with Liletta. It shouldn't be that different. So I don't have a really good explanation for this. I just thought it was interesting. Maybe I don't know if one's newer and there's been more, time for reporting. I think they controlled for those things, but it does answer that question. The OBGYN will be like, nope, there's no increased risk of acne. And it does differ for IUDs. It's not just that you went off an OCP. There is a difference between a copper IUD and a levonorgestrel IUD.
I know that was always my explanation. I thought I was so clever. I'm like, it's not the Mirena, it's that you're not on OCPs anymore. And they'd be like, but now I can't say that anymore. I'm back to looking as dumb as I've always been.
Oh,
wow.
It just took one brief report.
Yeah. It's pretty much story of my life.
What's always interesting to me about these kinds of articles, though, is reporting bias. So, right, because if you got acne or hirsutism or alopecia, we as the derm, we always ask, well, did you get a new hormone releasing? Oh, it was probably that. And then the patient calls and reports it to the FDA. Well, if somebody with got a copper one, I would be like, well, it wasn't your IUD. And then the patient's not gonna get online and report it to the FDA. It's hard to ferret these out, but these are big numbers. I mean,
I agree. And the authors did say that was, that basically made that exact point. Perhaps we just assume that it's not the IUD when it's a copper IUD. So there is probably some reporting bias, but
on the other hand, in all the years since these came out, I can't think of a patient who's a female who I've seen and they've been like, oh, I got hormonal acne. And the top of my head, like, oh, did you get a Mirena? Like just because you heard it over and over and over again. Never did somebody get a copper IUD before they, got new onset acne. So it certainly fits, but I don't know. I'm not. I don't want to admit that Patton might be right about the just coming off of the oral contraceptives, but I'm not going to rule it out yet.
All right.
He's right about the scratching. I'm right about this, man. Just don't disagree with me.
Pat, next article. Patton, what do you got?
My second six-pack paper was by Amara et al., January 2025, British Journal of Dermatology. It was titled Efficacy of Dupilumab for Treatment-Resistant Grovers, a retrospective study, single-center retrospective chart review. The authors reported on 10 patients diagnosed with Grovers unresponsive to mostly topical therapies and treated them with Dupi standard AD dosing. Did itching improve in everyone? Yes. It completely resolved in 6 of the 10, improved in 2, and wasn't reported for the other 2, but their Grovers completely went away. So let's just say that the itching completely resolved in 8 of the 10 and improved in 2. Did Grovers go away in 7 out of 10? It resolved. There was 0% BSA at follow-up, which, by the way, that's a weird way to judge Grovers, is it not?
BSA.
I don't even know how you did
it. Just smushed together the little...
Yeah, it's like pinpoint...
BSA, yeah.
Right, so I wasn't sure, did they just take a body area? Like, hey, your whole stomach is covered with Grovers. I'm just going to count your whole stomach as being affected. They didn't really go into that, but I thought that was so weird because this is a retrospective chart review. Have you ever...
How do you make
documented body surface area Grovers?
The Grovers area and severity index. I do that all the time on my Grovers.
Did you? See,
are you going to add that
to your chair? And 3 of the patients in whom it didn't go away, it got better. Only 1 patient didn't really have a good response. He went from 15 to 10 BSA, which again, kind of weird. All of the patients with some sort of atopy, so maybe they had a history of asthma. One of the patients, I think, did have a history of atopic derm, had resolution of their Grovers. Biopsies weren't available for every single one, but man, I mean, Grovers is pretty easy to clinically diagnose. So we have Dupi for Grovers, and I think like this is doable, right? It's not like this is a disease where you'll be like, I'm never going to be able to get Dupi, because you could easily call this just a manifestation of atopic derm, which I think Grovers. I always thought of Grovers as it was almost an irritant sort of contact dermatitis, and it just had a different morphology than your eczematous type of rash. It was just this papular sort of weird rash. But I always thought of it as, these patients just have sensitive skin, and this is a reaction.
I'm pretty sure they have now shown that Grovers has some kind of a somatic mutation that affects your follicles. I feel like I read that somewhere a couple of years ago. I'll have to look that up and come back.
Okay.
But
The acantholysis makes it, I think, harder for me that you see histologically to say it's just like a dermatitis, right? It's like histologically very distinct.
A fair number of Grovers. I mean, I think if you biopsy enough little lesions, you'll see sponge derm and EOs on some of those as well.
Now we understand why Patton says it's easy to diagnose clinically, because 9 out of 10 cases diagnosed by Patton were sponge derm on biopsy. Yeah, it was Grover's.
Yeah. Right.
So wait. So Emma Gutman is the senior author on this. So she's a very basic sciencey oriented person. I can't think of why. I can think of why Dupixent would help with the itch, but it's hard for me to think of why it would help with the lesions going away. Did they do any, staining of the biopsies for IL-4 and was there any basic sciencey stuff in here?
No, this is a very, very short. It was like a 1-page. It was a pretty lame paper for me to choose. Not that the results were lame, but there wasn't much to it.
No, that doesn't make it lame. It's useful because these are.
I didn't mean. I phrased that wrong.
Yeah.
Like it was pathetic of me to be like, I'm just going to take this paper because it's like 2 paragraphs. After I did that JID paper, I needed a break. Will I use Dupixent for Grovers? Of course. Why not?
Well, and if they're itchy enough, you're right. It's not unreasonable to call people with itch and a rash where you're like, I don't really know why you got this.
All right, so there is a single nucleotide variant in ATP2A2 gene that is associated with Grover's disease.
That's Darius.
Yep.
Yeah, so it's like a somatic mutation that for some reason localizes to like hair follicles.
Huh.
Yeah, that's why you don't see Grovers in young kids, because you got to be old to get the mutations.
Sure.
And they were all C to G or G to A, indicating it's potentially UV light-induced mutagenesis.
There we go.
Unbelievable. What was
right.
happening today? What was Grover's first name? What was Dr. Grover's first name?
William.
No.
Halbert.
Ralph
Grover. All right.
Oh, you know what? He actually did a follow-up study. So his original report was like in 1970. It was like 6 patients. He did like a follow-up report in the 80s where he took 375 patients with Grovers, and they did have, I think, a statistically significant higher history of like atopic diathesis stuff. So it was like in his paper that did seem to occur, like atopic history did seem to occur more frequently in Grovers.
And it is interesting that in this article, almost everybody had some kind of an atopic comorbidity.
Yeah.
It is.
Yeah, okay.
So maybe those are the people who respond.
They did. I mean, everybody with an atopic diathesis got better.
Okay. All right. Let's move on to our last paper here. This one was mine. And again, this paper has such a great point. So it's discrepancies in patch testing, timing, and outcomes, a retrospective analysis of the pediatric allergic contact dermatitis registry. So and this is by Sandler et al., but the senior author's a buddy of mine, Jeff Yu, who's at, I think he's at Harvard. And so they looked at this pediatric allergic contact dermatitis registry from 2018 to 24, 459 kids in there who had a positive patch test. And so what they were somewhat looking at was how long does it take from getting dermatitis to getting patch tested? And essentially they found out that people with skin of color, it takes longer to get patch tested. Okay, I can kind of understand that just because it's a little harder to appreciate the erythema and some of the characteristics, and maybe it's partially socioeconomic reasons as well. But that wasn't the interesting part of the article. The interesting part was this. So there are very, very few studies of outcomes with patch testing. So meaning there's kind of this assumption that, if I send you for patch testing and you're allergic to fragrance and there's fragrance in your body wash, that must be what's causing your rash. Well, there's very, very little data to back that up. And so most of the data, so it's one of the things I've been talking about at lectures recently, is that only about 10% of people who have a relevant positive patch test will clear. So about 50% will improve some, and 50% won't improve at all. And so if you're diagnosing contact dermatitis based on a positive patch test, you are misdiagnosing half of your patients, only partially correctly diagnosing 90%, right? The gold standard for diagnosing contact derm is people get better whenever they get away from something, right? So they looked at that. So this was an article where we did have this is the first ever data I've seen that's follow-up data on pediatric patch testing and contact dermatitis. So of the 459 kids who they looked at, they stratified by improvement after allergen avoidance. In across the board, if you just look at all the kids, 1/3 had no improvement, a half had partial improvement, and then about 20% had complete improvement. So a little bit better than what some of the data shows in adults. But then if you look specifically at the kids with atopic dermatitis with a known diagnosis of that, numbers were pretty much exactly the same. 1/3 got no better, half got somewhat better, and then 17% got completely better. So first, what you would say there is 17% of them didn't have atopic dermatitis. 17% of them had contact dermatitis that was misdiagnosed as atopic dermatitis. But then the other really interesting thing, so there's a lot of discussion over the years about, do people with atopic derm, are they more or less likely to have contact dermatitis? So there are a number of studies looking at rates of positive patch tests in people who have atopic dermatitis, and they've been kind of across the board. Some have showed more, some have showed less. But the takeaway here is, again, if you're using a positive patch test, you're generally going to be wrong, because when you look at the odds ratios, kids with atopic dermatitis versus kids without, if you were allergic to fragrances and you had atopic derm, your odds ratio was only 0.3, so 0.29. So 70% less likely to get better, meaning that probably 70% of the cases were false positive because you had atopic dermatitis and a bad skin barrier. With antimicrobials and preservatives, things like formaldehyde and isothiazolinones, the odds ratio was 0.44. That was not statistically significant, but still a pretty decent number. But then surfactants, so cocamidopropylbetaine, which has been put out there as that's the one that's more common in kids with atopic dermatitis, your odds ratio was 0.03. So you were 97% less likely to improve than a kid who had a positive patch test who didn't have atopic derm. And then metals, the odds ratio was 0.26. So 74% less likely to improve. So the takeaway for me was that in kids with atopic derm, sure, it is still reasonable to patch test them, and it is still totally reasonable to say stay away from your allergens, but it really looks like a huge number of these are false positives where the kids are not going to get any better whenever they avoid.
So is that really a false positive, or is it just not the whole story?
So that's a great question. So it's a fault. I would describe it like this. I would call it I think they are false positive irritant reactions. Okay. Now, it might be that they are, you're right, only partially getting better because they've also got atopic dermatitis or whatever. But the main takeaway that I want people to have is, if you get the kid patch tested and they have a positive relevant patch test, don't be like, oh, avoid this allergen, and then come back and, oh, you're no better. Well, maybe you missed and avoid, maybe it's the laundry detergent, or maybe it's the air freshener, or maybe it's they're using an air freshener at school. And then they come back and well, maybe it's this, or maybe it's that. And then they come back, well, maybe it's this, or maybe, and so the kid then goes 2 years of avoid this, try and avoid that, where you just say, okay, we tried avoiding 3 months, you didn't get any better. Then you treat them with Dupixent. Right. And then if they don't get any better when you treat them with Dupixent, then you go back and say, okay, maybe there is stuff that we missed. But so it might be combo contact derm and atopic derm. It might be one or the other, but just don't think that a positive patch test is the end of the story.
So how do we know that some positive patch tests aren't just sort of like a worse skin barrier and an irritant reaction. And so it's almost like if you just do IgE or RAS testing for allergies, right? Like you get positive tests to foods that people eat. So it's not necessarily a good test for like things that for clinically relevant, like clinically relevant result. Is that potentially the case for patch testing too?
So so if you had asked me that in 2016, I would have said, no, it's a very accurate and the blah, 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 blah. But once we got Dupy, which I think works in atopic derm, I think it rarely works in contact derm because there's a lot of people who would get worse, and then you'd fight when you put them on Dupy, they're, oh, you're allergic to them. I think that patch testing is a very non-specific tool. I think that there are lots of people who have a positive patch test, but they don't really have contact derm. They've got atopic derm and a positive patch test.
So you've been patch testing forever. 97% of patients with cocamidopropylbetaine. Was that sort of your sense of stuff? Would you get these patients that would have that positive reaction and like vast majority of the time they never got better?
I would say that other than facial dermatitis, so face and hands, routinely I would see people like we'd find something, cocamidopropylbetaine, and they'd get better. Like that was pretty reasonable. Mm-hmm. But people who had like a widespread dermatitis, really rare that they would get better whenever they would avoid the stuff in their body wash or the this or the that or the other.
So the 97% didn't like blow you away. You're like,
no,
yeah, I get to you.
It more was like, oh my God, that's what I thought, but nobody's ever like, I'd say the 97% did surprise me, but also I didn't patch test a ton of kids, right? I don't really like seeing kids.
Okay.
So I didn't patch test a ton of them. So it didn't blow me away. Right. I was like, yeah, that makes, especially now that's only in atopic kids, right? So in kids who don't have atopic derm, it might be that, when you get a positive, it's really a high probability of getting them better. But that's the kind of the big takeaway is positive patch tests in people with atopic derm take with a huge grain of salt. And only call it contact derm once you've seen them get better with avoidance. If they don't get better with avoidance, then try treating them for atopic derm. And then if they don't get better with treating for atopic derm, then go back and look for, did we miss something, right? Did we miss an allergen? Did we miss an exposure? Whatever. But it just drives me nuts when I hear people say that a positive patch test is the gold standard for diagnosing contact derm. Every time somebody says that, I want to be like, you're a moron. Because if say you have a positive patch test, and you understand, I don't have to go through the whole thing. But if
we got it.
You do not have to. No,
yes,
at all. I take it you don't make a lot of your income on patch testing anymore.
All right. Well, guys, I did want to mention one thing that Dr. Patton brought to our attention. The Respegaladusilucan from Nectar Therapeutics was designated as a high priority something by the FDA. It's just a cool thing. It targets the IL-2 receptor complex and it stimulates T regulatory cells. And so it's rather than blocking something, this is one of the first times it's activating something to treat atopic dermatitis. And it may give people a chance for a really long-term, if we get your regulatory T cells controlling everything, maybe it really can give people a long-term remission. So interesting that was designated. What's the designation called? Do you remember?
They asked for a more rapid approval pathway,
like a high priority, or some. There was
something like
fast track.
Fast track. It was fast track. That's it. It was fast track.
Well, maybe we should have looked this up before going on the air and just making shit up.
Yeah, that's
it was designated something.
It's designated. It's important.
It's important. That's
a
it.
drug
And it's got
to watch.
It's got
You
a
know
cool
what?
name, Red.
Derms on Drugs will be following this carefully and closely, and we will keep you updated on any progress.
On respegaledusolukin.
Right.
Yeah.
Mostly if we learn how to pronounce it. That will be the first
We'll
big
update you
update.
on it. Well, all right. So I want to thank everybody for tuning in this week for another great and entertaining, hopefully, episode. If you've got questions, comments, ideas for stuff you'd like us to cover on the show, shoot us an email at questions@dermsondrugs.com. Again, that's questions@dermsondrugs.com. I hope you learned a few things. I hope you laughed once or twice. And I hope you're planning to join us next week. Until then, I'm Matt Cyrus.
I'm Tim Patton.
And I'm Laura Ferris, and we are Derms on Drugs.